Okay, we're about ready to get started. And thank you, John, for the workout. I'm gonna try to do, how many new people have we had in here? How many new people? Okay, so for some of you who are old and a little bit more seasoned and knowledgeable, just kind of bear with us for a couple of minutes because we're gonna do our Dementia 101s to answer some of the questions for the new people who are new to our group. Up on the screen, you should see a timeline for our different minority men's health programs. First virtual program, December 2021, and on through. We've had some great speakers, some great doctors here to talk to you. Today, you're going to hear from Dr. Walter Falconer, who is a member of the Georgia Urologist Medical Group, and he's going to talk to us about men's urologic health. But before I get to that, I'm going to talk to you a little bit more about Alzheimer's and kind of do it, I call it the Dementia 101 in the 5-minute space. So to answer some of your more frequently asked questions, what's the difference between dementia and Alzheimer's? Well, dementia is an overall arching term. There are several different types of dementia. Alzheimer's is the most widely studied and the one we know the most about, but it's followed by a mixed dementia, which usually affects people that look like us in this room. What a mixed dementia is it may be Alzheimer's mixed with vascular disease or somebody who's had a stroke. It may be Alzheimer's mixed with something called frontotemporal dementia. It may be Alzheimer's mixed with Lewy body dementia and any other thing that you talk about. Other types of dementia that you may have heard about are the brain health or brain disorder called chronic traumatic encephalopathy, something that occurs in people who've had lots of head trauma. It's been made famous by a lot of football players, right? So having lots of head injuries, whether you're in the military or a victim of domestic violence, is a reason for you to suffer from chronic traumatic encephalopathy. So how do I know that I'm at risk for memory loss? Well, we do know that cardiovascular disease is a confounding risk factor for developing a dementing disorder. So if you have heart failure, if you have atrial fibrillation, it means that you're at risk for developing a stroke, which puts you at risk for what we call vascular dementia. We also know that a 20-year history of uncontrolled, and I'm going to say it that way, uncontrolled hypertension leads to dementia in later life. But the main risk factors for a dementing disorder are living long enough, so being older, gender, women are more likely to develop Alzheimer's. But when it comes to vascular disease and things that we have some control over, most of us are going to suffer from some part of vascular disorder. So having high cholesterol, hypertension, diabetes, anemia, chronic obstructive pulmonary disease, rheumatoid arthritis, those are other risk factors for developing a dementing disorder. So how do you diagnose it? Well, developing dementia is a process. Diagnosing it is also a process. It begins in your primary care doctor's office where you may do a memory screen, just like for women. And there are a few in here, and I'm just going to say this. If you're not one of the ones who's been given special permission, I've got to say this because they get upset. We're not supposed to be here, okay? So take that wherever you need to take it. And unless you're a special VIP and you know who you are, you don't belong in this room because we've been told that they don't want women in the room when they have these discussions. So that's my comment there. I'm leaving that alone. But how do you diagnose it? So you have a screening test if you are looking for cervical cancer. Today, we're going to talk about urologic health. For prostate health, to determine whether or not you have prostate cancer. You may do a digital rectal exam to determine whether you have colon cancer. You do a test on your colon to see whether you have blood in your stool. That is it may involve a digital rectal exam. It may involve putting stool on a little card, but more commonly it involves a colonoscopy. And yeah, on television they have Cologuard. That's for some people, but it may not be for all people. And at the end of things, to make sure you don't have colon cancer, you will end up with a colonoscopy. So screening in your doctor's office, 5-10 minutes. If that screen is abnormal, there are other things that need to be done. And one of the things that needs to be done is to make sure that the signs and symptoms that are being observed are not attributable to something else. Lots of people mistake their medicines. They don't take them correctly, and so they have side effects as a result of that. Maybe they're sleepy, maybe they're confused. And so our job as primary care doctors is to make sure that you don't have vitamin deficiencies, that your medications are being properly prescribed and properly administered, such that those aren't the reasons why. We also have to look for things that are treatable. Vitamin deficiencies, vitamin B as in boy, vitamin D as in dog, vitamin B12. We do a syphilis test because those things are things that can be managed. Unmanaged syphilis creates or manifests as dementia in later life. That was the problem with the Tuskegee experiment. Lots of people developed syphilis, and when a treatment was available, they were never given the treatment, so they were manifesting signs of latent syphilis. Dementia is a sign of that. That's why it's a critical part of the dementia workup. Now, what if I have a patient or a parent with memory issues? Well, a lot of us have symptoms that look like dementia, but I would say 10 to 15 years ago, unless you were in an academic medical center, chances are you had some type of dementia, but we don't really know whether it was Alzheimer's. But Alzheimer's does have a genetic component. And it's more likely if you carry the genes ApoE4, you're heterozygous, you have 2 copies of that gene. And there are other genes that are associated with it, but most commonly studied are ApoE4. And that's not a routine test that a doctor can order. We can order it. It's a genetic test, and your insurance won't pay for it. I just need to tell you that, okay? Because people like to think there's some kind of way they can afford everything, and we're important. We're pretty important, and
well-to-do, but if you want that test, get it, but don't expect your insurance to pay for it because it's not going to, okay? So ApoE4 is one of the main genes that's studied, but there are about 30 or 40 other genes that are associated with Alzheimer's in particular. And to be tested for those things, they're really pretty much only available through research, but you can get genetic testing in a genetic counselor's office if you have associated risk or definitive risk. If you have a parent with memory issues, I would tell you to get that parent to the doctor and talk about what you're seeing so that we can begin the comprehensive medical evaluation. It then involves an imaging test, usually a brain MRI, and that's one of the things we do in research here. The FDA approved test for diagnosing Alzheimer's is the amyloid PET scan. It's a test that costs $6,000 to $7,000. It is not covered by insurance. It's not paid for by Medicaid or Medicare. And it's largely used as a research tool because it's not covered by Medicare or any other private insurance. So if you want one, the free way is to do it through research. The more costly way is to ask for it and be willing to pay for it. How do you prevent dementia? Doing what you're doing here, staying engaged, managing your chronic medical issues so that you stay healthy and you keep this body of yours in the best functioning capacity that you can. Exercising. John was doing his little thing, and I love John's exercises in the chair because you do a workout. I didn't do it today because I didn't want my hair to get messed up. You need to exercise 150 minutes a week, walking, dancing, swimming, gardening, whatever makes you happy. Just move. And then, is there a cure? As of this moment, there is no cure for Alzheimer's or any other neurodegenerative process. I'm going to repeat that again. As of this moment, there is no cure or definitive treatment for Alzheimer's or any other neurodegenerative disease. We have 2 drugs that have recently been approved by the FDA for managing Alzheimer's, and they are what we call disease-modifying therapies, but they're not appropriate for everybody who has Alzheimer's. And right now, the side effects that are associated with them may be more risky than not having those treatments. As things progress, we're hoping that Alzheimer's becomes pretty much like an HIV infection, multiple drugs in combination, and eventually you'll be able to take 1 pill a day and make it so that you don't have HIV. Hopefully we'll get to that point with Alzheimer's. We are still researching, trying to better understand what therapeutics work. We're trying to develop less costly diagnostics. So one of the things that we offer through research is surveillance for you, but anybody in here over the age of 65, as a part of your annual wellness visit, should get an annual memory screen. And that's just a simple 5-minute test that's in your doctor's office. So that's my Dementia 101 in 5 minutes. And now for the meat of this presentation, I'm going to introduce you to Dr. Walter Falconer. He's probably your doctor. Where is he? He's over there. Okay. Many of us wanted to learn a little bit more about urologic health and keeping healthy. And as a primary care doctor, everything that has to do with the prostate isn't always cancerous. And I want men of color, women of color to start thinking of their health as a way to live healthfully and live a long life as functionally as we possibly can, and stop thinking of ourselves as walking, talking diseases. Yes, sir. Okay. I know you want to talk to Dr. Falconer, and we'll let you ask him questions. We will facilitate the question and answer session. For the question and answer session, if you can keep it to a question and not a commentary and not a testimony, we would all appreciate it. Dr. Falconer.
Thank you all so much for having me come out. This is extraordinary. I mean, I do a lot of talks in the community, and to see this volume of men is extraordinary. And I am moved by your efforts to take care of yourselves and therefore take care of your family, therefore take care of your community. These things are important. We need to be here in order to advocate change. And part of that is health. It's something that we historically, if you look at our fathers and grandfathers, never had communication. They never would sit down like this and have a conversation with one another. And as we talk about things like prostate cancer, and I know there are prostate cancer survivors in this room, that are here to share their journey. And it's important for each one to be able to teach one and learn about this. And we're going to talk about some conditions that affect us. But I tell you, I am moved by the number of people that are here. Thank you. Thank you. Taking the time to take care of our community and yourselves and your family. So I applaud that. Let me see. Okay, so a couple of things you want to talk about. And one, the prostate. You know, what is the prostate gland? What's prostate cancer? Some of the symptoms and things. So this is an educational thing and also a dialogue. We're going to have, some questions maybe at the end as we go through things. We'll talk about screening and early detection. How do we treat this? And then we'll talk about other conditions that affect us as men, like benign prostatic hypertrophy or enlarged prostate gland. And then we'll get down to erectile dysfunction, something that also affects our mental health and our family health and everything as well. So a little bit to start. What is the prostate gland? Okay. The prostate is our male sexual gland. I'm going to kind of step over here. So essentially, here's the bladder. Our prostate gland sits at the base of the bladder. Can y'all see that, gentlemen? I hope you, it's the red item here. And then we urinate, obviously, out through our penis. This gland is very vital for our reproductive health. It actually produces the semen that supports our sperm when we ejaculate. So we're, survival of the fittest. Sperm, when we ejaculate, the vagina is a very hostile place. And so those supportive nutrients and fluids help the sperm survive so it can get to the egg. And that's the function of the prostate. It's not a vital organ. We can live without our prostate gland. We can't reproduce without it, but we can live without it. And so it is a gland that goes through some changes as we get older. Now, we look at prostate cancer. How many men are affected by this? And when you look at this, most people say 1 in 24, 1 in 7. I'm just going to get to it. About 1 in 6 men. That means one person at this table, each table, has prostate cancer. Extraordinary numbers. And particularly in our community, in the African-American population, the numbers, the highest incidence in the world, are with us. This is a real disease, fellas. This is it. This is the number one cancer that affects our population more than any other group in the world. And we're going to talk a little bit about why you see that. So if you look at that, it's the second leading cause of death of men. Look at the numbers. Every 2 minutes, a new diagnosis. This is real, okay? And hopefully, if we do have it, we want to catch it early because there are differences in the staging when we catch it, early stage versus stage 4. That's what we hear about. So we don't want that. And so there's some symptoms of prostate cancer that we have to be concerned with. Men who have difficulty urinating or slow urinary stream or waking at night, stopping and starting, blood in the urine, and sometimes in advanced diseases, pain in the back or weight loss and things of this nature. And then the thing that's so scary about this is that most men in the early stages don't have any symptoms. And so if you wait till you have symptoms, the likelihood of it being something that's much more advanced is higher. And so this says, even if you don't have symptoms, doesn't mean you don't have prostate cancer. Not all men experience symptoms. So in the early stages, it's important to diagnose the patient through screening. Now, there's some risk factors. We think it's only an old man's disease. This isn't true. Last year we diagnosed about 10 patients in our practice under the age of 40 with prostate cancer. They all had family history. They all were African descent. So if you have a strong family history, it is important to say the younger people in your family, those survivors out here, this is a message that we should be getting out well before we're age 50 and 60. So this is something that we should probably be talking to 20-year-old men about prostate prevention. They need to be planting the seed now for your nephews and your sons think about the prostate gland because it's so real in our community. There was one study that was done in Temple many years ago. It did autopsies on all the people who had died of traumatic diseases. And they found that 9% of the 20-year-olds had prostate cancer, 15% of the 30-year-olds. So this is a real disease that actually starts at an early stage. So age can be a risk factor. Family history we talked about in the father, brother, son, and even on the mother's side. And we started talking about genetic testing and the BRCA things as we begin to identify people who are at high risk. And then race. We see a higher percentage in the African-American population. Why? We don't really know why. We think at the I'll tell you, the second highest incidence of prostate cancer in the world are with white Americans. So it's something endemic about being in America. If you carve out our cultural diet, how we prepare foods or the foods we eat, why we have a higher incidence of high blood pressure and heart disease, it's probably why we have a higher incidence of prostate cancer. If you take a native-born man from the East, from Japan, and they move where there's virtually no prostate cancer because their diet is different, you move them to the US and they mimic our diet, their incidence of prostate cancer and heart disease will begin to rise and almost mirror what we have. So we think some of this is our cultural diet. What's good is that we're starting to change. That's why the actuarials, the Social Security is mad because our life expectancy was supposed to be 62. We got someone, we listen to. We stopped frying the foods. We stopped eating the pork. We started doing the things that we needed to do for our heart. And they got mad because we were living too long. But you know what? Keep on living. Okay. Keep doing what you're supposed to do. Okay. And so who should be screened? Well, we recommend that every man over the age of 40 be screened once a year for prostate cancer. Okay. And it's easy to identify and follow the patients along. Okay. And then survival rates of early prostate cancer is almost 100%. Okay. So what tests? One is the blood test. The blood test is the PSA. That's a test. A lot of y'all, when you go to your primary care doctors, they're doing the PSA test. It's an enzyme that's produced by the prostate gland. It unfortunately is not a cancer test, but prostate cancer is one of the conditions that can make the PSA rise and elevate. And so when there's an elevation, it means there's some tests that the urologist has to do to evaluate and see what's the cause of the elevation. The other is I get mine checked once a year. I can't stand it. And I do this every day. I check men every day, all day. But when it's my turn, I get it, but it's necessary to put the finger back, and just check the prostate because there are some cancers that don't make PSA. And so you have a normal PSA and they'll have a nodule or not back there. So it is important to do both. Okay. Some people don't want to do both. Sometimes you go to primary care doctor, they say the blood's enough. It's not enough. Advocate for yourself. Like, I need you to check my prostate gland in addition to the blood work thing. So, and if some primary care doctors don't do it, they'll send the patient to a urologist. That's fine. We check prostate glands. That's what we do. We check prostate. So, and then we order biopsies only if there's an elevation of the PSA or we feel something that feels abnormal. And so the people think that because your PSA is high, it means you have cancer. That's not necessarily true. You can have a high PSA because of enlarged prostate and not have cancer, but you also can have a low PSA that's normal and still have prostate cancer. So it's important to be evaluated in these patients. What do we do if it's elevated? We feel a nodule. The next test is an ultrasound of the prostate. And this slide's we started to add MRI of the prostate as well to look at the prostate and see if there's anything going on within the interior. And then we do a biopsy. We take a small piece of tissue to analyze the prostate gland. And this other thing, Gleason score, the cancers are different. Some cancers are aggressive. Some cancers are non-aggressive. And we factor that in with our decision-making with prostate cancer as well. If you have it, unfortunately, the key is to be stage 1, that T1, stage 1. We catch this and it's inside the prostate gland. It's a seed in the apple. That's a good thing because then our goals are for a cure. Okay. So hopefully we catch this in the early stage and the discussion will be, how do you get this cured? As it advances, T2 is more cancer. And then 3, it breaks out of the capsule of the prostate, much harder to treat. Then unfortunately, those patients who have stage 4, they have advanced disease. It's come out the prostate, it's gone to the lymph nodes and the bones. But still, we have treatments for those patients as well. And so I tell patients it's important to make the diagnosis because we have treatments at every level that can help resolve this for the patient. What are our goals? To improve survival, get you cured from this, catch it early, cancer control, but also quality of life issues are important too. You don't want to be treated and then left with leakage and erectile dysfunction. Those things are important attributes in decision-making and should we do something. There's things we consider. So say a man's diagnosed at age 80, well, he doesn't necessarily need surgery. That may be too aggressive, but we have other treatments that work well. There's some younger persons that may need surgery. So we consider all this, the patient's life expectancy, their general health. You have to individualize every patient. There's no one formula for any of us. We all are different. We all have different outcomes. And ultimately, patients can make choices for themselves about the different treatments. So there are different treatments. One is nothing, active surveillance. Prostate cancer is a very slow growing tumor. So the time it may take someone to go from a stage 1 to a stage 4 sometimes can be almost 5 to 7 years. Okay. So if I'm 80 something years old, there's patients who choose maybe just to follow this along. Not something we recommend, and it requires close follow-up to make sure there's no change in those patients. So the other is radiation therapy. Well, radiation is there are different forms. One are radiation pellets or seeds that are placed in the prostate. The other is external radiation from the outside, the beams that are coned down. There's a new form of radiation called proton beam. Remember, across from the Fox, Emory opened that proton center. Those are variations of radiation. Surgery is, removal of the prostate, the physical removal of the prostate gland, either through, now we do it robotically. In the old days, we made big incisions. And then there are other treatments like hormonal therapy. There's wonderful immunotherapy. It was really the kind of cutting edge. Now we're able to identify what's the gene group and use specialized medicine that attacks the cancer at the cellular level. Extraordinary, the kind of things that we have available for men. We just have to know if someone has prostate cancer or not. And so this kind of talked about that. I just went through it. Active surveillance, just follow the patients with PSAs, digital rectal examinations, the MRIs, the radiation therapy, the two types, external beam, and then the brachytherapy or the seeds that are placed. And then that's the total removal of the prostate gland. There's another treatment called cryotherapy or freezing the prostate, which is also a formidable treatment. Make the prostate ice, and when it thaws, it destroys all the cancer. But a lot of those things are really geared toward cure, is catching the patient in stage 1 or stage 2 when it's early in patients. A little bit about the robotic surgeries, and we've evolved from that old open operation to something that's done through a scope. And there are patients who used to have that old big incision, now a couple of ports. Like we do robotics and laparoscopic surgeries in a lot of things now that really are beneficial to the patient. So thinking ahead, what if it returns? What if I take it out and it comes back? Are there treatments for the patients? Well, what we expect is that PSA to drop to 0. What's unique with prostate cancer is different than a whole lot of cancers. There's a blood test that tells it's a tumor marker where the cancer is. Most cancers don't have that. PSA was never designed as a screening test. It was originally designed as a surveillance test after taking the prostate gland out. I remove my prostate gland, my PSA should be 0 because I have no prostate gland. And we still use it in that format. So men who have been treated for prostate cancer, our prostate cancer survivors, they know they come in to get their PSA checked. They expect it to be 0, and we follow the patient. That's why, and if it ever starts to creep up, then we can add a secondary treatment. So prostate cancer is a cancer that has the luxury of having that, whereas a lot of cancers don't. The patients really don't know where they are until, unfortunately, the cancer comes back and rears its ugly head. One of the patients we've seen that is in breast cancer. I had a successful mastectomy and radiation, then several years later, the cancer returned. It didn't return. It never left. You never got it all in the first place. But with a prostate, you can tell where the patients are. And it's something that we implement all the time in patients. So, and then there's some treatments. Say if the surgery comes back, you can add radiation therapy. If you do the radiation and it comes back, you can do the freezing for the patient. So there's a host of different treatments for patients. Here's the take home. Prostate cancer in African Americans, highest death rate any racial group in the United States. This is real. Okay. And we need to get over ourselves and our ego about getting checked and getting tested. This is just part of it. And if we want long life, we want longevity, and ultimately it's God will on longevity, but quality of life. We want to be here. So we can't bare our heads and pretend like we don't have prostate glands. We have them. Do they turn in cancer? They do. Okay. And so we have to get in front of this for patients and just get over these kind of tests. It's really interesting. You have the mindset of some men who just don't want to be tested. And I respect that. I do. Everyone has a right to their own choices for their own body, but it is probably not smart. And we do need to get screened and go to the doctor and just be there to make sure everything's okay. We use the term in our community, silent killer. It's real. Things like blood pressure and diabetes, these things we can feel fine, look good, look great, but on the inside, something's broken. And we need to be able to evaluate it and fix it for patients. So again, significant number of deaths in 2016, higher incidence in African-American male, because they're less apt to be screened, unfortunately, patients. Things like this change, move the dial. This kind of information. I know each one of y'all are going to leave here and share the information with your friends, your family members, your coworkers, your buddies you grew up with. It's important that we start having a dialogue. That's a little interesting test. I know I talked about, I would do talks and tell men, what's the number one cancer among American women? Every man raised their hand. Breast cancer, breast cancer. I know that. How do women screen themselves of breast cancer? Well, they do mammograms, breast examinations. I'll say, okay, what's the number one cancer among American men? Crickets. How do men screen themselves for prostate cancer? Crickets. Women have been so effective that we know what they should do for their number one cancer, and we don't even know what we should do. And so we need to start thinking about, what's my PSA? Have I had my prostate gland checks? Empower this number one cancer so that each of us understand that we need to be getting our prostate checked once a year, just like our wives need to get their mammograms and their pap smears. We need to get our prostate glands and become empowered by that. So we talk to one another. Hey, buddy, you get your PSA? Hey, buddy, that's where we want to go. And these kind of things help that, move that dial. So I'm proud of that. Prostate cancer prevention. Well, okay, we're at high risk. I'm at high risk. You're all at high risk. American men are at high risk. And so are the things that can lower our risk? Well, what we find is a heart-healthy diet is one of the things. We think the incidence is due to associating with high fat, high cholesterol. So if you can support a low cholesterol diet, a vegan diet, the meats and things, it probably lowers the risk of patients. There are also some herbal formulations that have been shown to lower risk as well. Things like lycopene, which are in tomatoes, or these herbal components of vitamin D and zinc have been shown in saw palmetto to lower prostate cancer risk in patients. So, and they're just natural things. I tell patients there's nothing proprietary about it. You can go to the store, binge prostate formula, and just start yourself on these natural things that don't have side effects, but have also been shown to lower prostate cancer risk, reduce our body weight, exercise, antioxidants. We all, with COVID, got into the use of zincs and these antioxidants. These things are important for general immuno health in patients. Exercise, stop smoking if you're smoking now. Just find a way to break through it. A lot of people are. And I always put good sleep hygiene. One of the things that all of us are deficient in is sleep. There was a time that television went off at 11 o'clock. You just went to bed, But now you sit up there and we flick the channels as if you couldn't tape the game. But no, we're going to sit there and watch it at 2 o'clock. And, it's just crazy. But most of us get by with about 4 to 5 hours of sleep. When in reality, if you just cut the TV off and go to bed, you will actually do better, recharge the battery. So actually having an active plan. My wife and I, we took the television out of the bedroom. Because I would sit there and flip the channel. And the minute I walk in the room, I just go to sleep. And so those kind of things are important. And most of us are sleep deprived. It's just, that's the time how we live now. So adhering to good sleep hygiene will be very, very important. This next thing I'm going to talk about is BPH. And it's a little confusing because now we're talking about a benign process of the prostate. It's really enlargement of the prostate gland. When our prostate enlarges as we get older, I used to be young, I walk into the bathroom, public bathroom, old man with gray hair be standing there. I urinate, move on. He's still standing there. I'm out the door. Okay, that's me now. Okay, I'm standing there. A young cat comes in like, still here, shaking, dribbling, tissue. I'm with you. Okay. And so those things happen with age as we get older. So, and enlargement can block the urethra, and then the patient can have these symptoms of enlarged prostate. But again, remember, they also can mimic symptoms of prostate cancer in patients. So essentially the anatomy, again, remember that picture, there's the prostate gland here. And then as it grows, it can compress the channel that which urine flows. And that happens as we get older. So now instead of having a big open channel with a big strong stream, now we're peeing on our shoes. You have to that's a part of the aging process in patients. And you have to distinguish that from prostate cancer, in patients. So that's the natural enlargement that can occur. And so if you look at these symptoms, these were the same symptoms I put up on the slide of prostate cancer. So I tell patients, if you have these symptoms, number one, you need to get evaluated for prostate cancer, and then we can address these symptoms as well in patients. So must rule out cancer first. PSA, digital rectal examination, prostate exam. That's the first thing. I always got to make sure this isn't prostate cancer. These aren't patients who don't have symptoms. These are, you've been going to the bathroom for yourself all your life. When it changes, you're up all night, you can barely get it out, you're struggling. So at a minimum, get in to get checked. And then there are also things that we can do if it's not prostate cancer and just enlargement, we can help the patient. The studies we do called a post-war residual. We see how much urine is left over in the bladder, the uroflow, what's the flow, the velocity of the flow. Then we sometimes will take a look into the bladder with the scope to see what's creating the blockage, or are there other things in there like stones or other bladder tumors. And then sometimes a prostate ultrasound just to overall determine the size. And then there are treatments. There are different treatments. We're going to go over these, and some of the conservative management. It's just to reduce the bother. My question I always ask patients, how bothered are you by it? You're getting up once or twice a night. Does it bother you? Because this is medicine. This is American medicine. Y'all know we got a pill and a surgery for every problem. It's a pill and a surgery. It's multiple pills and surgery for every problem. And so I think a question a lot of doctors don't ask is, well, does it bother you? You know, we're getting older. I get up twice at night, maybe too much information, and it doesn't bother me. It doesn't bother me to the point that I need to take medicine or have surgery, okay? And that's okay. I'm okay with that, you know? And so it's a question, just because we have change, you know, it doesn't mean you necessarily have to do something. We can't run a mile like we used to. That we change, we age. And so some of it is embracing it and knowing, at least I can urinate. There's a difference if you can't. And so those kind of things. And so you can reduce the bother symptoms. Some men reduce intake of fluid before they go to bed. You know, if you drink a large lot of fluid, you're going to wake up in the middle of the night. Then refrain from prostatic and bladder irritants, spicy foods, alcohol, caffeine, those things that just irritate the body. What I've learned to do, the things that just get crossed off the list, stuff they used to, remember, no, we grew up, stuff we used to love. I used to love hot sauce. I mean, I'm from Atlanta, you know, I can't eat it anymore. I mean, I just, you know, every time I would eat it, it would irritate me. And eventually I said, 1 + 1, you know, maybe I need to stop doing this, okay? And so you begin to learn yourself and learn that I just can't eat this anymore. I just can't drink this anymore. Or if I do, this is going to be the outcome. And you begin to learn. I always tell patients, when you have something that you wake up 4 or 5 times a night and you're not, what did you eat last night? You know, and you begin to figure that maybe I need to stop doing this, or drink more water and things like that to help things. Healthy living and exercise is important. Refrain from prolonged sitting. Now, one of the things that some men have, I see a lot of drivers who drive, you know, people who sit at a computer all day. And it's that constant sitting on the prostate. Our prostate lies back in our buttocks, so it puts pressure on the prostate gland that can create some inflammation and change. So getting up, and the one thing we saw with COVID, when everybody was at home and virtually working, they were sitting a lot. We saw a lot more men coming in with some issues. I said, well, have you been getting up? He said, I just sit at the desk all day. I'm not going down to the office anymore. And so I counsel drivers and people who sit about every 30, 45 minutes, just stand up just for 10 seconds, let the blood flow. It helps to keep the prostate healthy, improve. Frequent ejaculation. Well, we know ladies in it. Okay. So that is important. You know, it is important for men to ejaculate. I mean, it's just the prostate holds the semen when we talked about. And so you want to have just a healthy ejaculation to clean the pipes and things. So that can be through intercourse or masturbation. I tell patients, you know, just it's important for us to ejaculate, not just have all this fluid build up in the system. So the herbal supplements that for BPH, just like for prostate cancer, saw palmetto reduces the size of the prostate. In the clinical studies, that's been looked at and shown to have science to it. Vitamin D and vitamin E have been also shown to improve things. Zinc supplements. One thing, we're zinc deficient. We used to get zinc in the soil, you know, in vegetables and things like that, but because we're so overproduced in our vegetation, there's no zinc in the soil. We don't rotate crops and things like that. So a lot of men will take zinc supplements. You know, during COVID, a lot of people taking zinc for the immune system. So I tell patients, continue taking zinc, lycopene, which are in tomatoes. So these are natural things that help. And some patients do fine on these things. Then there are some patients who don't and need the next step, which are some medications. One are alpha blockers, things like Flomax that open the channel up and allow the urine to flow back again. There are medicines that shrink the prostate, these 5-alpha reductase inhibitors. They block testosterone, the prostate shrinks. The medicines that stop the irritation of the bladder, the frequency and things. And some of these have side effects, you know, so you have to kind of weigh, does the benefit outweigh the side effect of the patient? For a lot of patients, it will. Some patients, they don't want to take that and they look at some other options as well. And then there's some minimally invasive treatments and procedures to reduce the size or open the channel of the prostate. I'll go over a couple of them. One is the UroLift. This is kind of a new procedure where we actually put a device in that opens the channel up. And so the slide, kind of cartoon here, this is the enlarged prostate. This is the implant. And this is really a live person then. So their prostate was enlarged. And then this is after it, with the UroLift in, it opened the channel up. So mimic what the medications would do. And so this patient would have an improved urination. So there's another treatment called water vapor. It's really steam. So we actually put steam into those enlargement areas, and it shrinks or reduces the size of the prostate that creates the blockage. There are other variations of that, the microwave, which does the same thing. You're trying to reduce the overall size of the prostate. We actually have prostatic stents or balloons. So we actually put, like cardiac stents, you put the stent in, it's pictured there, that sits in the prostate and opens it up, or a balloon that balloons it open, just like angioplasty for the heart. And then there's some surgical treatments that we do, a little more invasive. One is the OT, men call it the roto-rooter. You used to go in there and trim that prostate tissue out. And it was actually 30 years ago, the number one surgery that was done before the medication. The men who had large prostate, the only thing they could do was have this procedure done. It's a great procedure. It works. It opens the channel up. It does have some side effects in terms of, we call it retrograde ejaculation or some irritation. So, and we have all these other treatments now that patients need to consider. Is this a last resort? Yeah, I tell patients, we are there. There are some patients who present with, they're unable to urinate. Well, those patients have a catheter in, and usually those minimally invasive things probably won't work. So you have to get to this level. But the majority of men don't have to go to this level in patients. But that's an old procedure that we still do today. There's a variation of that called the green light laser. So now we use the laser, instead of to trim the tissue out, to laser it open and create the channel. All we're trying to do is recreate that channel so we can urinate with a big, strong stream. And then aquablation. This is this technology is incredible. Using water, compressed water, to open the channel up. That's a new treatment that really has some great efficacy. And then we go back to the older operations, looking in with the scope and removing the prostate gland, or the enlargement of the prostate gland for those patients. So there are a host of different treatments for patients if they have those symptoms. I'm gonna close with erectile dysfunction. And this is obviously something that's important for us. And it's really interesting. Erections are interesting, man. It's a combination of a psychological, hormonal, vascular, neurological, muscular response to give us an erection. It's actually science fiction. This doesn't make any sense. People, because there's a bone, it's blood, and it's entrapped blood in our penis that creates that. And a breakdown or failure of any of those components could result in erectile dysfunction. And there's a natural increase of erectile dysfunction as we get older. And so the anatomy, step over here, it's really our penis. Think about it. We're born with two of most everything: 2 arms, 2 legs, 2 kidneys, 2 eyes, 2 ears, 2 lungs. And we actually have 2 chambers in our penis that fill with blood. So there's a big blood vessel that goes down the middle and allows blood to flow in. And then the blood is disseminated through these smaller blood vessels. And when that happens, the veins collapse to hold the blood in. That's how we have the erection and maintain the erection. And it's over a period of time that's, fortunately, is short enough that you don't get lack of oxygen in the tissue. So you remember those commercials, you have erection more 4 hours, it's unoxygenated blood. Your penis is erect, there's no flow of blood, but the time period that we have the erection is enough for when it goes down that it returns with normal blood flow. And so there's a big vascular component to this in patients. And so there are symptoms: decreased rigidity. So I don't get as much blood in the penis. Loss of the erection. I got a good erection, but it goes down. Early ejaculation. I got a great erection, but I'm ejaculating quicker than I like to remember. Penile curvature. That's some men who have an injury to the sheath that fills with blood, and then they get some scarring and some curvature of the penis. Then some men have decreased libido or sexual drive. So now my testosterone level's low, and testosterone is the male hormone. That's the gas in our tank. Women have estrogen, we have testosterone. It's the thing that makes us hunters. When we're young, our testosterone is off the chart. It's all we're thinking about. As we get older, there's a natural decline of testosterone, but it shouldn't be too quickly. It shouldn't just fall out the back window. And so there are some men who have decreased sexual drive. And of course, it's hard for them to perform if they don't have the interest, And so things like the pills, like Viagra and things, don't really work on those patients because they still don't have the desire to match for the performance. And then sometimes patients get penile pain. So the different causes, we all think it's always psychological. That's wrong. Most of this is organic. There's usually a reason that we're having issues with our erections. And the more common thing is medications. What's the one thing a lot of patients take? A blood pressure medicine. Well, if you look at the physiology of erection, it's the presence of blood flowing into the penis. But what I need a good blood pressure, push the blood into the penis. Well, I take blood pressure medicines, which lower my blood pressure. It lowers it where I don't want it lowered, which is in the erection. So these men, unfortunately, as a side effect, can have some issues with the erection. It's a very common side effect from blood pressure medication. I tell patients it's important if you can do your best to get off blood pressure medicines by exercise and eating right, but it is an unfortunate side effect of medications. Neurological vascular disease. So also, remember, it's blood flow. And so if I have high cholesterol and I've had strokes or other kind of vascular disease, that doesn't discriminate. That actually presents in the penile chambers as well. One of the things when Viagra first came out, a patient would come to our office and say, I just want some Viagra. And they had erectile dysfunction. I said, well, have you been worked up? I said, no. Well, what we found was that men who have erectile dysfunction also have a high incidence of other vascular things. They have a higher incidence of strokes and heart disease. Now, lack of blood flow isn't just in the penis, it's in the other vessels as well. So those patients also need a complete evaluation of their heart, things like that, just to make sure that this vascular disease isn't affecting us in a more serious place. Neurologic conditions like multiple sclerosis or Parkinson's disease can affect that. The high cholesterol we talked about, previous surgeries, some of these surgeries we talked about, or prostatectomies or radiation sometimes affect the nerves that supply the male, or nerves that send the signals down for the male erection. So those things we have to take into consideration. Low testosterone is one thing. Penile injury is interesting. A lot of people think, can you fracture a penis? Yes, you can. It's actually a very common thing. If I have a rigid erection and get too much pressure on it, it's vascular. It will blow out. And so these patients will present to the emergency room with blood and things. And it's a surgical emergency. We have to go in and fix that, or they will have erectile dysfunction. So you can have injuries to the penis that can affect erections in the future. History and physical is important. Assess the medications, check the levels and everything. There's some studies we do. There's some patients who come see me, I've been put on Viagra. It's really an interesting area. It's the only place, I'm sure some of these patients have taken some of this medicine. You go to the doctor, they will take these pills. And done one single test on you. Just take these pills. They'll make you better. And they do. Viagra and Cialis works. But think about it. If you had chest pain, you better believe we're doing EKGs and chest x-rays and XYZ. Your stomach hurts, you're doing CAT scans, XYZ. Take these pills and you'll be fine. The problem with that is we haven't figured out why you're having the issue. And the goal should be, and that's why some patients will come in and say, Viagra used to work. Now it doesn't work anymore. Well, it's not that it didn't work anymore. It's a good drug. Is that you've changed over time. And so it is important to evaluate the patient. So penile Doppler ultrasound is an ultrasound test to look at the blood flow through the penis and really tell us what's going on. At what point are you having the issue? And nocturnal tumescent testing is one of the things, putting a band over at nighttime. Medications, the treatments, manage the medication. Like get y'all blood pressure medicines, those things will help. Oh, true, Viagra, Cialis, Levitra, those things are available. They're great drugs. They work, and for patients. A lot of men don't want to take them. They do have some side effects, but they do work for patients. So it's definitely something to consider. Penile injection therapy. You hear these commercials on the radio, come to the men's clinic. We'll guarantee your erection right there. Those are shot clinics. Essentially what you do, there's a medicine that you inject into the penis. The patients were taught to do it. And that medication then gives the patient an erection, okay? And men are, they inject themselves and they'll have an erection for X period of time. It's real interesting. I'm kind of get off of it. I was at the meeting, this is, 30 years ago, when the doctor who invented this technology, a penile injection, at our annual meeting gave his presentation. So we're all in the audience. And just like I'm talking here, he did his presentation. We're like, what are you talking about? You stick something in your penis. And then he closed his presentation. He said, maybe I shouldn't say it. He said, before I came out 15 minutes ago, I injected myself. And he stepped out from the podium and turned to the side. And that was the presentation. And we were like, oh my goodness, that really works, But that was his introduction. He's like, I injected myself. And since it was interesting, but that works. And a lot of men use those. But those shot clinics, they're available. One thing I tell patients about that, when you listen to them on the radio, come see us, we got this XYZ, they don't take your insurance. And that's where we don't mind the competition. I just want patients to be whole. My approach to patients, I care about your health. I care about your wallet. I understand, like, I don't try to gouge, pay, and so you go to a place where you have insurance covers it, but they don't take your insurance and charge you thousands of dollars for something that you shouldn't, because it's just wrong, and so these things that they offer, you can get at any urology office in any of my colleagues in urology all over the city. They do the same things that they offer there. So intraurethral therapy is putting the same kind of medicine into the tip of the penis. Penile rings and vacuum pumps are an option for patients that kind of pump things up. Testosterone replacement, if the levels are low, you can give men testosterone to improve the levels. Penile prosthesis is a penile implant. A lot of people may have heard patients have. I do a lot of implants in my practice. And it's actually putting a device in that can pump up when a man wants to have relation, and deflates it as well. So there are some men who fail all these other things, and the last thing is left is a surgical solution to those patients. So I put on the end something Gaines Wave. This is kind of new therapy that came out in Europe. These companies advertise. It's so. It's really, I think the shock wave improves blood flow in patients. What we found, we studied it in our practice. In patients who really respond to the pills, they do okay. Patients who don't really have a great response tend not to do as well. One of the challenges with it is not FDA approved. And so the patients have to pay all these thousands of dollars out of their pocket. We took it away from my practice because I didn't want my patients to pay thousands of dollars for something that may not work. I mean, it's just something that we didn't find a great benefit, but it is out there as an option for patients, and some patients have a benefit from it. So I'm gonna close here, and then we'll take some questions. Just take action. What you're doing today is an action, and I love that. And I want you to go out and share this information with your friends in the community. Be open. Gone are the days like my father, who was just so closed-lipped and quiet. And again, talk to your family. You got things going on. Let's share the information with one another. Talk to your doctor. Advocate for yourself. If you're not, this is Atlanta. There are a whole lot of doctors. If it doesn't match up, it doesn't mean anything's wrong with the doctor. Some kind of healthcare delivery, and we also look at some issues in terms of race and healthcare delivery. It doesn't match up with what you want. Change, because you're not going to change anyone, just like they're not going to change you. I'm just going to remove myself and go across the street and go to the person who least hits the bullets that are important for me. And so you have to advocate for yourself. You have to position yourself, demand that you get the PSA, demand that you get the DRE, demand of these things. That you're educated now. You come in, the patients are different. Back in the old days, I had the old Merck, she didn't know. But we go on the internet, we come to the appointment already armed up with information, which is a good thing, because educated patients are easier to take care of. Educated patients do better. They listen and they try and they work hard. So those things are important to me. If you're 40, get a baseline PSA, discuss the treatment options, and look at prevention. Patient, when I was early in my practice, a man would come see me once a year, check his PSA and DRE. And I sat back and said, I haven't done one single thing to help him besides be the person who drew the blood and did his rectal examination. And realize that there's a lot more information. It's really what you do on a daily basis that affects your health. And I started to get into talks about prevention and things like that, because it is the everyday that matters most. It's not just me checking your doctor checking you, it's what you do every single day. So prevention is important. And there are things that we can do in our general health and our diet that can help support our mental health, help support us to be better. And this is part of that initiative. So thank you. I know it's a lot, and I'll be happy to answer questions, but just, again, I'm so moved. I see patients and friends and people I grew up with, and it's just wonderful to have everyone come out. So thank you so much.
Okay. Thank you, Dr. You got to stand there. You hold the mic and you can walk around. I think
Okay.
We have people. No, you stay here. The way we're going to do questions, Mr. Dorbin and Mr. Lark have the microphones. So if you have a question, raise your hand and they will walk to you and bring you a mic. Okay.
We're going to start over here. Dr. Falconer, can you tell me how overactive bladder plays into this situation?
Yeah, it's a great question, because I talk more about the prostate, but the bladder, actually, it's above it. And overactive bladder are symptoms of urgency and frequency and urge incontinence, like losing your urine. And if you think about it, they almost mimic some of the prostate symptoms as well. But overactive bladder is a condition that both men can have and also women can have as well. Women don't have a prostate, but they can have this overactivity of the bladder. And it does play into it. Sometimes you can have both. You can have enlarged prostate and this overactivity of the bladder. The treatments are sometimes similar. A lot of it, we try some behavioral modifications, stop the caffeine and the alcohol and those kind of things. And then there are some different medications that work on overactive bladder. They work to stop the contractions of the bladder. And now bladder is it's a very passive organ. It just fills up. And when it gets full, it gives us a signal of fullness and we go to the restroom. That's how things work. That's how it worked all your life. Patients have overactive bladder. In the midst of filling, the bladder starts to contract and you're like, oh goodness, I got to go. The bladder's more in control. And so if you can stop some of those involuntary contractions and irritation through medications or diet and things like that, it can help. There are also some other treatments we do, like Botox. We're on Botox for our wrinkles thing. We actually put Botox in the bladder to stop those involuntary contractions. We also have something else called neuromodulation. So now we know that the nerves that come out of the spine that supply the bladder can be modulated through a device like a pacemaker to stop those contractions. So there's a host of treatment for patients who just have overactive bladder. And that's not just men, that's women as well. It's interesting because a lot of it's cognitive too. And so when you get into urination and things of that nature, particularly as we get older, and you look at other patients who have other things like Alzheimer's and Parkinson's, those signals of that cognition of urination can be affected. Now, some of the treatments in the question, like one of the treatments was an anticholinergic. It unfortunately is a medicine that almost created some dementia and crossed the blood-brain barrier. So we don't use that medicine as much as we used to in patients. So some of the treatments can affect the brain and mental health.
Got one more here.
Yeah, you was talking about the zinc. I usually take zinc with vitamin C if I have a cold. Is it okay in normal conditions to take zinc on a daily basis?
It absolutely is. I mean, it is something like a lot of people, we armed ourselves up when we had cold and flus like that. But the reality is because of zinc levels, and it's something that people don't check a lot. You go in for your blood, you don't check your zinc level. But yeah, it is something that you can take on a daily basis. And even with like vitamin C and the recommendations and vitamin D is one that just take those things on a daily basis to foster a more armed immune system. Yeah, take it every day.
It's just, he's currently being treated for prostate cancer, and he just wanted to kind of give a little bit of information.
Thank you very much. I'm one of the ones that have stage 4 prostate cancer, and I've had it for three years. My wife is the one that really keeps up with everything for me. So if you have a very good partner to help you on these things, it's worth the wait in life. She helps keeps me alive. But needless to say is that my PSA was very high, but now through treatment of medication, it's lower, very low now. And of course, my wife, she knows all the numbers and all this sort of thing. I'm surprised she's not taking notes now. But I just wanted to share that. And then when you go through that, when I was told that I didn't get the biopsy. And when it came back, and of course I went and they told me that it was at the stage 4. I really didn't know whether to cry or what to do. I was just stunned. I just didn't do anything really.
What's your
But
question?
then my question is, thank you.
Yeah. Well, listen, I appreciate your transparency. That's important. These are the kind of things, yeah, absolutely. Let's give it up for him. He's a 3-year survivor, a stage 4. And that's just with treatment. So it is important. The other thing I tell, and I don't put it on my slides, I talk about all this medical stuff. There's not but one healer. And I can sit here with white coats on and medicine and this and that. You better get your spiritual life together. Okay. And thank God for the blessings of what we have. And so that's equally as important in getting better and getting well.
Question over here. You mentioned earlier, we were talking about testosterone and how it affects the male level. We see a lot of advertisement on TV about raising your testosterone level. There have been boosters out there. How is that? Or the question is, can you have too much testosterone and how it affects the prostate?
Yeah, it's a great question. Yeah, you can't have too much. I mean, there's a range that's very normal for us, and so tell patients they'll come in, I'm taking the testosterone boosters and don't even know the level. So it gets dangerous because if you get too much testosterone, what it does, it thickens the blood. It puts the patients at risk, and also it doesn't create prostate cancer. But if someone unfortunately had prostate cancer, it will make the prostate cancer more advanced. So it is important. The patients we have on testosterone replacement, they're coming in, we're monitoring their levels. You know, we're monitoring their blood counts to make sure that they're not too high. So it isn't something that you should do on your own. Interesting, some of the herbal things they advertise, like ageless male and Nugenics, they really don't have a testosterone base to it, but still it's something that I tell patients, you know, that's the danger of trying to direct consumer marketing. It's okay. Those things are wonderful after I've been evaluated to make sure I don't have other things done. So, yeah, but it is a natural complement to what we need.
We have time for a couple more questions. We're going to do one here and then we'll take one over on that side of the room. Okay.
Thank you. I just recently had a traumatic accident on my cycling, where I was went airborne over someone and fell on my back. And the end result, after getting the last MRI, I had a concussion. As a result of that, it affected my urine. It made me started wearing Depends. Oh, there was some incontinence that set in. I'm back to normal now, but I'm just curious, could that have an effect on my bodily functions?
Yeah. Yeah, it can. I mean, again, a lot of that is cognitive. I mean, okay.
Questions, please.
So we'll make sure everything's okay. I'll see you. But yeah, you can't. I mean, those kind of head injuries and things they do, because a lot of this, it's that beautiful design of our body. It's vascular, it's neural, it's all these things have to be in sync. And so with an injury to the head, when there's the concussion is significant, things just aren't processing and sending signals down. And it takes a while. And unfortunately, you can hurt yourself more to kind of get things reoriented. But a lot of people say they learn to walk again. They learn, some of those things are true. And so, yeah, it can affect the urinary tract in that manner.
Question. So my father passed of cancer. His father passed of prostate cancer. No matter what I do, does that mean I'm still going to have cancer because of the family history? That's my question.
Great question. No, it doesn't mean it. It doesn't mean that you all may have some gene in your family, and the difference is their choices and lifestyle may have made it express itself differently in terms of the foods they may have eaten, or the environmental things they're around, or the stressors in life. So just having the gene doesn't absolutely mean that we haven't seen that the man's going to develop it. You can have a suppressed gene all your life, and if it just manifests itself when you're 85 years old, so what? And so it doesn't necessarily mean that. What it does mean is that you need to get screened. Someone like you with that strong family history, I'd say screen once a year. I screen this patient twice a year. Let me see what the PSA is doing about every 6 months. You're somebody who really needs to look at some of the preventive things and things to lower your risk of prostate cancer, because you only are on just from African descent. You also have strong family history as well. You can't bury your head. So I'm glad, because a lot of it we don't know about our ancestors. We don't know what a granddaddy, great granddaddy had or would have had if they had lived long enough. So some of it we're flying blind. So some of it is almost putting ourselves in that high risk group, even though we don't necessarily know what a great grandfather, if he would have had prostate cancer. I'm just going to assume that he did. And so I'm going to live like he did. And so, yeah, it doesn't necessarily mean you're going to have it.
Thank you so much for your wonderful presentation, Dr.
You're welcome.
In the coming months, we're going to have some events that will have a little loose schedule, and the gentlemen in this room will be able to have a little bit more room for dialogue and sharing our collective stories. So we certainly appreciate you for coming and sharing and giving us all this good information, and perhaps you'll come back again.
Thank you.
Will you? It's June and July.
Okay.
They have the discussion in June and July.
Be involved. I mean, I'm excited.
Yes,
about this. I mean, I would like to be involved in any way.
Thank you. Anything else, David?
That's it.
Okay,
Presentations.
thank you. So this is the part where we ask you to fill out your evaluation forms. Those are the white sheets. We also give you the yellow sheets if you're interested in research. You know, I mean, I try to be a good salesperson because, you know, at the end of the day, we want you in research. But the least invasive part of research is the Emory Healthy Aging Study. And we have people around here who can do that. Where are our coordinators? Where's Miss Tasha? Okay, Miss Tasha is the chief triage officer. If you're interested in research and you fill out one of those yellow forms, Miss Tasha is going to be the person who probably calls you back and sends you an email. If you are a man over the age of 70, the first person who's probably going to call you is Miss Crystal. Miss Crystal, right here. I know you all know Crystal, but we want you to fill out the white forms. Those are our evaluation sheets. That's really important for helping us understand how to make this program a little better for you. If you are interested, if you've filled out a yellow form before, don't fill another one out. But if you're really interested in research, fill one out. If not, don't worry about it. It's not going to hurt you. If you got to come again, we'll let you come again. We'll help you learn something. And if you feel like it then and you want to participate in research, you do that. We have several coordinators here who are interested in signing you up for research. I see Clark, I see Kristen, and Mr. Lark. If you're interested in research, and some of the ladies out front, in 2 weeks, we have what we call a research social. So if you filled out one of those yellow forms, we'll bring you back and have an opportunity for you to ask any questions you want to ask about research.